So I invite Randall Kimple from the United States. And so I'm going to talk about control of radiation response by P53 in HPV-positive head and neck cancer. Thank you.
Good morning, and I want to thank the organizers for giving me the opportunity to present this story to you today. I have no disclosures today. So our lab is interested in understanding really the last question that Maura posed, which is how should we be, or how can we use HPV status in patients with head and neck cancer to optimize therapy for them? And in pursuit of that, we have developed a tumor graft model system where we take patient tumors from the operating room and implant them directly into patients. And what you see here is one representative example of that, where we follow the tumor growth in immunocompromised mice over time. And these mice were treated with just 1 week of radiation therapy, 2 gray, so a normal radiation fraction per day for 5 consecutive days, and followed over multiple weeks, over multiple months, really. On the right of this screen is a Kaplan-Meier type curve looking at the proportion of tumors that have quadrupled. And if we compare the untreated mice with those that were treated with radiation, we see a hint of a fairly significant response with this radiation treatment that is really only 1/7 of what a patient might receive who's undergoing definitive radiation therapy. So this gives us a hint that some of the data that I'm going to show you next is hopefully relevant. We have been using a variety of different head and neck cancer cell lines in which we have validated the HPV status by Southern blot, by real-time PCR looking at E6 and E7, by Western blots looking at loss of P53, loss of RB, and other molecular markers, and have assayed these cells for a variety of different treatments. What I show here is treatment with a single fraction of radiation, differing radiation doses on the x-axis and the surviving fraction on the y-axis. And the pattern that I think is fairly clear here is that the HPV-positive cell lines are significantly more sensitive to radiation than the HPV-negative cell lines. Now, when we use these same cells and look at sensitivity to standard chemotherapeutics like cetuximab or cisplatin, what we see is a big jumble where there's a lot of overlap in the sensitivities to those drugs. When we use these exact same cell lines as tumor xenografts, so implanted into mice and treated with radiation, in this case, rather than treated with 1 week of radiation, treated with four doses of radiation delivered over 2 weeks. So certainly a suboptimal treatment design, but that really came from other goals of that treatment. But when we look at those that were HPV positive compared to those that were HPV negative, we see that the HPV positive cancers again have a significant delay in tumor growth compared to the HPV negative cancers with this low dose radiation. So in an effort to understand what is underlying these differences in radiation sensitivity, we've performed global gene expression analysis using Affymetrix arrays. We've taken our 8 HPV positive and negative cell lines. We've looked at baseline and at 3 subsequent time points following a single dose of radiation. And these 32 samples have been run in biologic triplicates. And what we see is that there are clear differences as were expected between HPV positive and HPV negative head and neck cancers. And while a complete analysis of that data is still ongoing, if we look and focus just at using gene ontology analysis at genes that are involved in the P53 signaling pathway, we see significant alteration in P53 pathway genes. And included in this is actually P53 itself. So we are in the process of validating a number of these and hoping that they provide us some additional targets and avenues of investigation. But when we look here at a real-time PCR assay looking to validate the changes in P53 seen, so this is looking at various time points following radiation at P53 expression levels. The HPV negative cells on the left, we see very little expression or very little change in expression following radiation, whereas in the HPV positive cells we see a significant upregulation in gene expression, in P53 gene expression. We've validated this with Western blots looking both at total P53 and also at activated P53, and we see activation of P53 following radiation in these HPV positive cell lines. This P53 activation, we believe, is resulting in a very significant G2M arrest. So here I show data derived from cell cycle analysis using propydium iodide and flow cytometry, and looking at the proportion of cells that are in the G2M stage at various time points after that single fraction of radiation. And again, what you can see is that HPV negative cells have a slight G2M arrest that largely resolves by 48 hours after therapy, whereas the HPV positive cells have a very significant G2M arrest that's also prolonged in its duration, so that by 48 hours, many of these cells have not returned to their baseline cell cycle distribution. Likewise, we see a significant increase in apoptosis, and this is a luminescent caspase assay, activation assay. And we see slight increases in apoptosis in the HPV negative cell lines, but much greater degree of apoptosis induction in our HPV positive cell lines following radiation. Excuse me. So what I want to put forth is a proposed model and give you in the last few minutes a little bit of data that's really focusing on this model, and this is that normal oral mucosa containing wild-type P53, when it's treated with radiation, you get a normal P53 response as it acts as the quote-unquote guardian of the genome. It causes growth arrest. It sort of helps activate DNA repair pathways, and if cells are unable to repair DNA, they undergo cell death. HPV negative head and neck cancers have a high proportion of mutations in P53 that causes the normal typical responses to be blunted, and it's often or sometimes thought that HPV positive head and neck cancers lose P53 activity, and while it's certainly true that they have less P53 as a result of E6, we believe in the data I'm going to show you suggests that there's still a small amount of wild-type P53 that's available that following radiation can be activated and function in a normal way to activate these pathways that I've shown you in the first few slides of this talk. So here is another clonogenic assay. This time, rather than the cell lines that I showed you earlier, this is a immortalized human tonsillar epithelial cell line that we've obtained from our collaborator Al Klingelhutz at the University of Iowa. The black line represents the vector alone stable cell line. The red line represents cells expressing HPV16E6. The western blot shows loss of P53 in the E6 expressing cell lines, but still a small detectable band of P53. And this apparently small difference in sensitivity, we believe in a clinical setting where patients receive multiple doses over 7 weeks, results in a potentially meaningful change in tumor control probabilities. On the left here is, again, that same clonogenic assay that I showed you, and on the right, we've looked at the effects of further knocking down P53. So the initial graphs here, the red is an unirradiated surviving fraction, or the clonogenic survival. With radiation and a scrambled siRNA, we see good tumor kill. But using a P53 specific siRNA, we see a loss of that radiation-induced cell kill, suggesting that P53 is really playing a critically important role in regulating the radiation response in this HPV positive or HPV protein expressing cell line. The Western blot at the bottom just shows that P53 levels in this E6 cell line are in fact further knocked down by P53 targeted siRNA. So in conclusion, what I hope that I've shown you today is that we believe that at least in our model systems, that HPV positive head and neck cancer cells are more sensitive to radiation than HPV negative head and neck cancer cells. That this radiation sensitivity appears to be mediated through activation of residual P53, through induction of a G2 arrest and apoptosis. I think, and I certainly agree with Dr. Gillison, that this question of how we should really personalize therapy for patients remains unclear. We certainly look forward to the ongoing clinical trials that are helping to address that question, but also hope that the systems we're developing are going to be able to help elucidate better ways to treat both HPV positive and HPV negative patients in the coming years. Thank you very much. I appreciate your time this morning.